So the acute abdomen covers quite a wide range of conditions. There are lots of potential causes of acute abdominal pain, and that's essentially what we mean by the acute abdomen. Emergencies whereby the patient presents to us with severe abdominal discomfort. It may also be associated with some abdominal distension. It may be that the animal is obviously in pain and uncomfortable as a result of that. It may be that vomiting or diarrhea are signs that are associated with that as well. Surgical things perhaps a bit more obvious. Generally something has gone wrong, something has broken, burst or become obstructed. So uroabdomen, we've generally got rupture of a bladder, for example. The blocked cat we were talking about before lunch, the bladder has gone on to rupture. Generally that animal will be more comfortable after its bladder has ruptured, but then will be uncomfortable as time goes on. GDV with distension and twisting of the stomach, foreign bodies obstruction, and septic change, where we've got another type of peritonitis but with infection and bacterial causes. Things like mesenteric volvulus, where we've got a full twist of the intestinal mesentery, and intussusception, where we've got telescoping of the intestine. So lots of potential causes, and these lists are no means exhaustive, but they're the sorts of conditions that we're going to be thinking about. And those may be medical conditions. They may be presenting with abdominal pain. Both of these dogs have abdominal pain. The dog at the top is quite tucked up, has cranial abdominal discomfort, has a very classic sort of hunched appearance, and is sort of bent over as a result of that. Dog here is sort of adopting the sort of praying position. It's just been sick, but is trying to relieve cranial abdominal pressure by raising its hindquarters and bringing its front end down, so it's relieving some tension within the cranial abdomen. And both of these are sort of classic pictures of dogs that have abdominal pain. What we don't want to miss is the sort of surgical condition that, if we leave untreated, isn't going to be easy to treat. This is a case I saw last week. This was a German Shepherd that was actually quite well until about 12 hours before we saw it. Developed really quite severe abdominal discomfort. Imaging was relatively unremarkable in the first instance, but the dog was getting more and more uncomfortable despite quite potent opioid analgesia, so we went to surgery, and this dog does have a mesenteric torsion, so the whole of the gut has twisted around the root. Unfortunately, there's not much you can do about that, even if you see it in the first instance, because all of these loops at the bottom that are this sort of brownish colour are devascularized and becoming ischemic and necrotic, so they're not going to be repairable. But this is the sort of worst case scenario. This is the sort of thing that you don't want to miss and try and treat medically, because this dog unfortunately isn't going to get better regardless of what we do. So these surgical obstructions and emergencies we need to deal with and try to get to the bottom of as soon as possible, because if we don't treat them, we could end up with a position where we've got a worse off animal and we're having problems because we're not recognising the condition soon enough. So how do we approach these cases? What do we need to know? Well, we need a little bit of history. As we've said with all of these emergencies, signalement is going to be helpful, the age is going to be useful, so younger animals are going to do silly things and eat things that they shouldn't do, whereas older animals perhaps are going to worry more about tumours as causes of obstruction and worry about neoplastic disease. With history, things like parvovirus, whether the animal is vaccinated, what its history before the owners had it will be useful. Any known dietary indiscretion if the animal's been through the bin or potentially had access to something that it shouldn't have done. Things like diarrhea and vomiting can be helpful historical signs to know if there's GI involvement, any trauma, any history of medications that the animals are on, or actually also animals or medications within the home that the animal may have had access to that could have caused problems. So these are the sorts of surgical things that we don't want to miss, as we said, and then there's lots of indiscretion and medications that can cause problems as well that we really want to try and avoid as problems or not miss or identify as problems, so we can hopefully get to the bottom of things. When we're doing our clinical examination, there's lots of things that we'll look at. It's going to be very similar to what we said for our sort of primary survey and then more general survey. We're perhaps going to spend more time doing abdominal palpation, very carefully palpating the abdomen, both with our fingertips but also with the flats of our hands as well. Sharp palpation is useful for identifying abnormalities. Sharp palpation, blunt palpation is more useful when we're trying to distinguish abdominal pain and just seeing where the animal is uncomfortable. So we tend to use a combination of both. One of the things we tend to forget when we're doing examinations is to look under the tongue. This is sort of a classic string foreign body that we see in young kittens and puppies that have been playing with string, and it's got caught around the base of the tongue and then going off down the intestine and generally causing it to be quite corrugated. Finding it's the easy bit, taking it out of the intestine when it's all got bunched up can be more difficult, and we want to try and identify these sooner rather than later, as the string tends to end up sort of slightly cheese wiring through the intestine, and that can cause an awful lot of intestinal damage and be quite hard for us to repair. So let's talk through a case. This is Meg. She's a 4-year-old border collie. It's an agility dog, so very active dog. Got very committed owners. She'd had no previous history. She'd been quite well in herself until about 3 days before she presented to us. She'd been vomiting during that period, so mainly bringing up food at intermittent periods after she'd been fed, and she had signs of small intestinal diarrhea as well. There was a little bit of straining consistent with the small intestinal diarrhea potentially causing some problems within the colon, but she wasn't sort of markedly straining or having any blood or mucus associated with the diarrhea. She didn't want to eat, and she was resolutely refusing even tasty food, so sausages, chicken, all sorts of those things that owners were trying to tempt her with. And she was quite frequently adopting the praying position, so going down on her front quarters and lifting her hind quarters, that position to relieve cranial abdominal tension. And that's something that people generally say is associated with pancreatitis. It's not, it's a position that's associated with cranial abdominal pain. And the things in the cranial abdomen that can be uncomfortable would be the pancreas, so it's got to be on our list of things that are causing a problem. But splenic or hepatic distension, biliary tract disease, gastric ulceration, duodenal ulceration, anything within the cranial abdomen that's causing pain or being distended or inflamed can cause that to happen. So praying position isn't specific for pancreatitis, but it does suggest that there's abdominal pain. Have to be a little bit careful with lurchers or sighthounds because they'll also adopt that position when they're not very well. It's a sort of play or submissive type position in some dogs as well, and they will tend to do it when they're uncomfortable generally rather than they have cranial abdominal discomfort, so sometimes we can be misled, but generally it is a sign that we associate with cranial abdominal disease. So on clinical examination, Meg is quite markedly dehydrated. She's got quite marked skin tenting, so she's going to be about 10% dehydrated. The abdomen is tense and uncomfortable, so it makes it very difficult for us to do general abdominal palpation. It's very boarded and it's hard to actually feel normal structures. She has poor peripheral pulses and is tachycardic, so we've got signs of hypovolemia, and she vomits on admission. That was associated with me prodding her abdomen and trying to feel it. So she's quite uncomfortable and generally quite worried about how this dog is. So we're going to have to think about how we approach this patient, and we've talked about our approach to patients generally when they're collapsed and not very well. First off, we're going to try to get intravenous access. Here a cephalic catheter is going to be very straightforward to gain access with. We're going to place our catheter and we will start giving fluid therapy. What fluid we give, we're probably going to choose a crystalloid, probably a balanced electrolyte solution, so probably going to choose lactated ringer solution. How much to give? Well, we're probably going to do our volume resuscitation, so 10 to 20 mils per kilo over 10 to 15 minutes, reassess, give 2 or 3 boluses, and then try to correct the dehydration. So she's about 10% dehydrated, so she needs 100 mils per kilo of fluid in addition to maintenance requirements, which we'll try and assess over the first 24 hours of hospitalisation. And there are other things as well. She's definitely uncomfortable, so she's going to need some analgesia. We'll revisit potentially what analgesic options we're going to use for this patient in a bit. And then we're going to want to think about some diagnostic tests. At the moment, we don't know why she has abdominal pain, and we need to try and get to the bottom of things quite quickly. So there are lots of reasons why we might see abdominal pain. There are lots of abdominal organs that can be involved. The GI tract, the pancreas, as we've mentioned, the spleen can be responsible for more pain than perhaps we give it credit for. The hepatobiliary tract with biliary duct obstruction and cholangitis and inflammation is also important. The urogenital tract, where we've got distension of an organ or occlusion of an organ, so urethral obstruction, for example. And then the peritoneum, and we tend to forget about the peritoneal organ, the covering, the visceral and parietal covering of the abdomen. But there's a huge surface area of visceral covering around the abdominal organs and also parietal covering around the abdominal wall that can become inflamed and therefore cause pain. So peritonitis, septic or sterile will cause us to have quite marked discomfort. And this is a rather silly dog that ate a whole ball of string, didn't get stuck, it vomited most of it back, and was quite lucky to actually have it removed in that way. But it's one of the more sort of lucky sort of abdominal discomfort cases. So lots of diagnostics, lots of potential ways that we can evaluate these cases, and there's a long list of things that we would think about. I'm just going to talk through some of these sort of options we have in terms of diagnostics and then go back to relate them to our case. So generally when we think about abdominal pain, we usually start with abdominal radiographs, and they're the most sort of useful abdominal imaging from the point of view of we're familiar with them and they're quite readily available. It's quite a cheap thing to do, it's portable, we can move it, we can ask other people what they think of the image or send them to an imager to have a look at. And this is one of the things I like where we are working at the moment, because our radiologists hate coming into the practice to help us with things, but you can email them an image in the middle of the night. They don't have to get out of bed and they can have a look at it and tell you what's wrong, and you have a helpful hand from afar in that respect. So radiographs are quite useful. Abdominal ultrasound is the next sort of test we would go for in terms of imaging. So it tells us about organ distension. It's not so useful if we've got gas, because gas in a hollow viscerus doesn't transmit ultrasound images, so we won't be able to image them very easily. And then if there's any fluid, collecting that will be helpful with abdominocentesis or potentially a diagnostic peritoneal lavage, and we'll talk about those in a second. And there's lots of lots of blood tests that would be helpful in terms of things that might give us information about what's causing problems or abdominal pain. So biochemistry may tell us what's happening with the liver and the kidneys. The pancreatitis, difficult, we'll talk more about tests for pancreatitis, but amylase, lipase, CPLI, they're all tests that potentially have some place in trying to make that diagnosis. And then there are more specific tests if we're worried about the urinary tract, urinalysis, and contrast studies if we're not sure whether there's obstruction. So we'll start by thinking about radiographs, and radiographs are quite a nice diagnostic tool for the acute abdomen because they show us quite clearly where everything is, or hopefully they show us clearly where everything is. We can look to see where the organs are, and we can look to see that they're in the right place with the right positioning, and we can make sure that there isn't any free abdominal gas, we can make sure there isn't any distension, we can make sure everything looks to be where we would expect it to be. And we can also tell about abdominal detail. If there's a loss of detail, it suggests that there's serosal inflammation within the abdomen, which gives us a clue that there might be peritonitis, and we need to look more closely to see where the fluid is present. And it also helps us to look at the extra-abdominal structures. So sometimes we can be concerned that we may have abdominal pain and we can't find what the cause of that is. Looking at the lumbar musculature and the back are very helpful. Back pain, lumbar pain, discs and sublumbar abscesses are all things that can be misled as abdominal pain. So if we don't find an abdominal cause, we'll often very carefully palpate the spine just to make sure that we're in the right place and we're following the right course of action, because abdominal and back pain can sometimes be quite hard to differentiate, and even with us and our neurologists, we'll have quite heated arguments as to whether the neurologists think the animal's got back pain and whether we think it's got abdominal pain. Sometimes we win, sometimes we don't. It's just difficult sometimes to tell what's causing the problem. So radiographs are good because sometimes it's fairly obvious what's wrong with the patient. I'm not going to ask you to vote to see what you can tell what's wrong with this patient, but sometimes you take a radiograph and you can really clearly see what's wrong with the patient. It's perhaps not so easy to remove it. I don't know how this dog ate this, but it wasn't a straightforward thing to remove. Had a surgery to remove it. Usually we try to remove things endoscopically, but I think that's a bit too big for us to try and find, and stomach's got quite a lot of food in it, so it would make it potentially quite tricky to try and find it. GDVs, fairly obvious again from our x-rays. We can make that diagnosis fairly easily. We've got a reverse C shape. We've got a shelf of tissue here which indicates that we've got a full torsion. So the stomach is twisted around on its long axis and we've got a full torsion. So we've got distension, so we've got gastric distension and also torsion with volvulus. And quite a lot of aerophagia as a result of that. There's a lot of gas that's present here in the small intestine. If we find this, we know what we need to do. We medically stabilise the patient, we treat its hypovolemia, we try to decompress the stomach, so passing a stomach tube or a trocar so that we can decompress the stomach and try to reduce the distension within the stomach to try and alleviate any risk of gastric necrosis. And then we need to operate. But generally we're operating maybe 12 to 24 hours after we found the GDV rather than rushing in to do surgery immediately, given that we want to try and treat the signs of hypovolemia and try and improve the systemic circulation rather than rush to take the dog straight to theatre and anaesthetise it. Here again, we've got a sign of a pretty horrible looking abdomen. We would be very worried if we took a radiograph like this. It's very hard to see where the abdominal viscera are. We've got loops of intestine, but they're very distended and they don't look normal. There's some fecal type material here. There's what looks to be free gas up here. And then if you look carefully, it's not obvious from the radiograph, but you can see the crura of the diaphragm very obviously, and there's free gas here. So we don't normally see anything up here other than the liver, but you can see that they're highlighted quite clearly. So there is free abdominal gas here. So we've got free abdominal gas. We probably have rupture of an abdominal organ and gas escaping into the abdomen. So this is very likely to be associated with septic peritonitis due to an ulcer or a rupture of the GI tract. Again, we know what we need to do. We need to stabilize the patient and go in and try and surgically repair the problem. Prognosis is going to be very guarded for septic peritonitis, even with aggressive and early surgical intervention. Prognosis is about 50-50 in terms of animals making it. So it's difficult. We would talk very carefully in this instance, given it's very severe, about whether that was the right thing to do or not. But some animals do make it, and some animals do very well despite very severe abdominal changes. Here it's very obvious that there's an obstruction. We can see that quite clearly. This is a bottle stopper that's causing a problem. But if we couldn't see that, if there was no sort of radiographic foreign body, the rest of the X-ray does show signs that are quite consistent with intestinal obstruction. You can see the small intestinal loops are much more distended than we would expect them to be. Here that's quite clear, and we would, I think, all be fairly happy that this dog had an intestinal obstruction that we needed to try and evaluate. But there are some objective measures that we can use that help us to try and be a bit more certain as to whether we have intestinal obstruction or not. And we can use the ratio between the width of the depth of L5, so the body of L5 here, against the width of the distended loop of small intestine. And anything over 1.6 times the depth of L5, so the depth of the body of L5 from here to here, is very strongly suggestive of intestinal obstruction. So in the middle of the night, if we don't have a radiographically visual foreign body that we can see nice and clearly as we do up here, we can use this ratio to try and help us to leave some support to there is a fact that there's an intestinal obstruction. And this is a fairly old paper now, but it was based on about 200 dogs. It was a study that Francis Barr did, and it's about 98% sensitivity and specificity. So they were very rarely wrong that there wasn't an obstruction. And as long as you explain that to the owner that they can't see the obstruction, it's far better to have a negative explore laparotomy and not find a foreign body than to miss a foreign body and find 2 or 3 days later there's an obstruction that you wish you went to surgery for. So a couple of cases out of every 100 that rule is going to be wrong, but most of the time you're going to be right with that distension. So a useful thing just to back up your suspicion that there might be obstruction. Contrast studies are sometimes useful, sometimes they're not. We, to be honest, don't tend to use them too much anymore because we rely on ultrasound and endoscopy to look in the stomach and the small intestine, but they can be helpful to highlight filling density, filling loss and densities within hollow organs. So here is a bore within the stomach, which is highlighted by contrast that's been given. To be honest, we probably would see that with ultrasound, but if you're struggling with ultrasound and can't see, then giving positive contrast would be helpful in the form of iodine, and you would be able to hopefully see. It's tricky because you need to put the dog in different positions to try and highlight it, and they are a bit labour intensive, but there are perhaps better ways than using contrast to see things. Now we might put the dog through the CT scanner, for example, and that would give us a very nice image of what's happening. This is a cat with abdominal distension, and this radiograph probably isn't that helpful because we can only see that there's fluid here. So we lose the opacity that's present. We have this ground glass appearance. This is really quite marked ascites. But what if there's less fluid? And this is our patient Meg. This is the radiograph that we took of her. And we'd expect to see some of the abdominal organs. So the reason for us taking the radiograph is to see if we can see anything that's causing abdominal pain, anything that might be in the wrong place, and look at the integrity and positioning of the abdominal organs. So we can kind of see the liver shadow. This is the pylorus, so the stomach axis is kind of in the level that we would want it to be. The kidney shadows are in the right place. There's loops of small intestine here and a bladder. We've been giving fluids quite aggressively, so that's a good thing. But down here it all starts to get a little bit tricky to see what's going on. There's loss of serosal detail, even though it's not really projecting very well, you can't really see what's going on down here in this area. So we do have a loss of serosal detail. So is that because there's inflammation? Is that because there's free abdominal fluid? It's very difficult to tell just by looking with a radiograph. So in that instance, doing ultrasound is very useful. And we did ultrasound of Meg to have a look in that area, and what we could see when we looked at that is that the pancreas looked very abnormal. Normally it's quite hard to find the pancreas, it's definitely above my ultrasonographic ability, so I have some images that help us to do that for us, but this was really obvious, really thickened, very big, very heterogeneous in terms of its appearance. It was very bumpy, and it's very bright when we're looking at it. And around that area in the mesentery was very inflamed. There was serosal inflammation and a small amount of free abdominal fluid, which was causing the loss of serosal detail on our radiograph. So abdominal ultrasound is really helpful when we've got abdominal disease, because we can try to look at things quickly. And how much we can use abdominal ultrasound for really depends on the ability and the skill of the person that's looking, and also on the how expensive your ultrasound machine is, what the capacity of your machine is. So if you have a very poorly sort of detailed machine, you're going to get less information than if you've got a very fancy machine. And I'm lucky to work with people who spend all their lives looking at ultrasound and some very expensive machines, and we can generally find what we're looking for. But in the middle of the night, if we're on our own and we're just trying to work out what's causing abdominal pain, we can try to make things very straightforward. And generally what we'll try to do is what we call a fast scan, where we're looking essentially for free abdominal fluid and looking for the structure and the position of the abdominal organs. So scanning for free abdominal fluid is usually fairly easy. It's obvious to spot where fluid is most of the time around organs. And then we can go from there. We can try to look at the liver, the spleen, the intestine. We can try and be fancy and look at things like the pancreas and the adrenals if we want to, but it really depends on the machine and our experience as to how we do that. And here we've got an effusion. If we find an effusion, we're going to want to try and tap the effusion. And with ultrasound, hopefully it makes it a little bit easier to try and see where we're going to tap and take our effusion from. But even if we're not very helpful, we're not very happy doing ultrasound guided abdominocentesis, we can still try to take samples of abdominal fluid just blindly, and a lot of the time we will get samples that are helpful. Knowing what the fluid is very useful from the point of view of trying to work out the reason it's there, in the sense that if we've got peritonitis, what we're trying to work out is whether it's septic or not, because if it's septic, it definitely needs surgical intervention. Whereas if we can medically manage things, the prognosis is likely to be better in the longer term. So the indications for abdominocentesis, essentially whenever we've got abdominal fluid that we want to look at, if we're worried that there's septic peritonitis, for example, the animal has a disease process that might mean it translocates bacteria through the gut, or we've got an unexplained inflammatory focus, or the animal's got abdominal pain that we can't establish where it's coming from. Essentially, it's very safe for us to do blind abdominocentesis in the same way as it is to do blind thoracocentesis. If we don't know the fluid is there, we'll just go just behind the umbilicus, about 5 centimetres behind, usually in the midline. Sometimes we'll go below that, so we're on the dependent side, the animal lying in lateral recumbency, and just using a needle or a syringe to try and gain a small amount of fluid. And if we're wrong and there isn't free fluid, then it's unlikely that we're going to do any damage. If we go into the spleen, again, it's got a nice fibrous covering, it's not going to cause a problem. Similar with the intestine. So we're not going to cause any damage if that's the case. The disadvantage with abdominocentesis is that it does require quite a lot of abdominal fluid for us to be able to tap it blindly. If we're good at ultrasound guided abdominocentesis, then we increase the rate of us being able to do it. And if we do it blindly and we get blood from the spleen or intestinal contents, then we're going to have misinterpreted findings. So we do have to be a little bit careful that what we're seeing fits with what's happening with the patient that's in front of us. If we're concerned that there is fluid that's present and it's quite hard for us to tap that, we can do a diagnostic peritoneal lavage. We do tend to use these out of hours a little bit when we're not so good at trying to collect pockets of fluid in the abdomen. And essentially what we're doing with diagnostic peritoneal lavage is to place a catheter into the abdominal cavity, lavage some saline into the abdomen, tip the animal backwards and forwards, and then collect some of that fluid back so that we can look and see what might be causing the inflammation. And where this is useful is where we've got unsuccessful abdominocentesis, when we haven't been able to collect the fluid that's present, or where we expect there's inflammation there and we don't know what the cause of that is. For example, if we've got really corrugated duodenum, which is usually because there's serosal inflammation on the outside surface of the duodenum, or if lots of the mesentery within the abdomen is very hyperechoic, so suggesting there's lots of mesenteric inflammation or serosal inflammation within the fat and steatitis, then doing a diagnostic peritoneal lavage will be very useful to try and understand what's causing the problem. And this is a case where we did diagnostic peritoneal lavage. We can see this is the liver, the gallbladder, but the whole area around the mesentery is just very, very bright. And this was a very odd case. This is a dog that had just mesenteric steatitis. But it was really hard to know whether this dog could have had septic peritonitis, and lavaging the abdomen with some saline and collecting that back so we could look at it was very helpful in terms of making a definitive diagnosis. And it's really easy to do. It's really straightforward. We just take a catheter, our intravenous catheter, so probably 1921 gauge, something like that. We make a couple of incisions along the side, so we've got several holes in it. Have the dog lying in lateral recumbency, clip and prep the abdomen. What we'll do then is just caudal to the umbilicus is to place a little bit of local anaesthetic. We'll then slide off our over the needle catheter into the abdominal cavity, connect up some fluid, lavage in about 10 to 20 mils per kilo of saline, so it needs to be isotonic, so 0.9% sodium chloride or lactated Ringer solution. Tip the dog backwards and forwards, so we're rocking the dog from side to side, and then try to collect the fluid back. So we're instilling the fluid in here, rocking the dog backwards and forwards, and then trying to collect the fluid as it comes back. And you'll be amazed actually if you do this how little fluid you're able to get back, because it's actually quite hard to collect it, and the peritoneum is quite good when it's well perfused at absorbing that fluid, so we don't get very much of the fluid back, but it's very useful at excluding septic peritonitis and looking for the causes of inflammation if you're not able to collect free abdominal fluid. So back to Meg, we know from our ultrasound that Meg has a very enlarged and quite hyperechoic pancreas on ultrasound, and given that we do some bloods. As medics we like doing blood tests a lot, we perhaps do them a bit too frequently, but there are things that we can see on the blood test that would be suggestive of pancreatitis, and we've got an elevation in alkaline phosphatase suggesting we've got irritation within the biliary tract, and a positive CPLI, which is a good test for pancreatitis. It's by no means perfect, but it suggests that we've got pancreatic inflammation. So it really does suggest that we've got pancreatitis, which is what's causing the abdominal pain, and systemic inflammatory response syndrome, which is what's causing her initial signs, that she's got inflammation caused by the pancreatitis that's leading to vascular changes. So we've got signs where we've got activation of inflammation causing blood vessels to be dilated and a loss of vascular tone to give us poor peripheral perfusion and poor peripheral pulses when we're examining her. So pancreatitis is quite a common condition. We see it quite a lot. We probably underdiagnose it a lot of the time and potentially overdiagnose it when we're thinking about causes of abdominal discomfort. And the reason that it's difficult to diagnose is that there isn't one definitive test for pancreatitis. And it's one of those things, it's a bit like building a jigsaw puzzle of trying to have pieces that fit together to give us a diagnosis and an answer that fits. So you need to have clinical signs that are supportive, blood work which is supportive, ultrasound and imaging findings that are supportive, and if possible a biopsy, although that's generally something that we don't obtain very often. So this unfortunately is a dog with post-mortem confirmed pancreatitis. This is a dog that really didn't do very well. It's got really severe acute necrotizing pancreatitis. This is the pancreas, looks really horrible, lots of hemorrhagic change through the mesentery, lots of saponified fat here overlying the pancreas, and quite a corrugated looking duodenum. So we talked about that before, where the duodenum is very, very bunched up. It's caused by serosal inflammation and irritation. And this is really quite difficult for us to try and treat and not nice. If we biopsy this pancreas, I'm sure we would find there's inflammation in almost all of the areas that we biopsied. But pancreatitis is quite difficult because studies have shown that the inflammation tends to be quite patchy. We only see inflammation in specific parts. So even the gold standard of pancreatic biopsy as diagnosis can be difficult because we may biopsy a part that doesn't have inflammation in it. So making a definitive diagnosis of pancreatitis is quite difficult. And that means we have lots of tests, but none of those tests is perfect. They don't have perfect sensitivity and specificity. So we can have false positive results and we can have false negative results. So it does make it quite difficult trying to make a definitive diagnosis. And the tests that we use most commonly, the amylase and lipase and CPLI tests. We've also got a TLI test as well. The TLI is quite an old test now. It's a really good test for us to look for exocrine pancreatic insufficiency, so looking at pancreatic function, but it's not a good screening test for pancreatitis. If it's elevated, it's quite specific. It means that pancreatitis is present, but it'll only show up in about a third of cases that you see that have pancreatitis. Lipase will go up in about half of the cases. Abdominal ultrasound, at least in dogs, we can find about 2/3 of the cases. In cats, it's about 1/3. It's a lot less sensitive. And the CPLI test gives us a sensitivity of about 82%. So for every 100 dogs with pancreatitis, we're going to find 82 of them using a CPLI. So there'll be 19 dogs that will have pancreatitis that won't have a positive CPLI.
How good is the FPLI?
The FPLI, similar values, it's about 80%. Yeah. So very, very similar in terms of sensitivity. So we need to bear that in mind. If we've got a dog that looks like it's got pancreatitis but a negative CPLI test, it may well still have pancreatitis. So use your clinical acumen rather than relying 100% on the blood test looking for pancreatitis. And this is why looking at the TLI is perhaps less useful than looking at PLI. This is using the feline values, but with pancreatitis, TLI goes up and comes down quite quickly. So within the first 48 hours of pancreatitis developing. So if we look in that first 2-day period, we will find it's elevated, but if we look after that, it's returned to normal. Whereas the PLI stays up and stays higher for a lot longer periods. So for at least the sort of first week of treatment, it's higher than we would expect. So it gives us a much bigger window to try and find that there's an inflammation and elevation. So it gives us a much better chance of trying to have a positive result to increase our suspicion of pancreatitis. So how do we treat pancreatitis? Well, in Meg, she's obviously very uncomfortable, so we're going to want to give an opioid analgesic. So methadone would probably be our treatment of choice. Wouldn't be wrong to give morphine, but at least when I give morphine, it tends to make animals vomit, which may not be the right thing to do if Meg is vomiting here. So methadone is perhaps better. If she's very uncomfortable with giving the methadone frequently, then fentanyl patch to try and level out some of the peaks and troughs of opioid analgesia would be helpful. And we tend to use a lot of adjunctive infusions of lignocaine and ketamine. MLK is the older version of that where we mix everything together. We're now trying to use these infusions singly. We'll use lignocaine and ketamine to try and make sure animals are uncomfortable or comfortable. And non-steroidals are a bit controversial in use of pancreatitis. If you look at some of the older studies looking for causal factors for the reasons why animals get pancreatitis, you'll see that steroids and non-steroidals are associated with the development of pancreatitis. We do use them in the treatment of pancreatitis, but we're careful not to to withdraw them if we see the pancreatitis gets worse. So from the post-mortem picture, I showed you loads of inflammation associated with the pancreas, lots of inflammation. And non-steroidals, very good way of trying to limit that and to try and settle it down as much as possible. But if the pancreatitis gets worse when we're giving non-steroidals, then we try not to give any more. We obviously need to try and treat the systemic inflammatory response syndrome to try and improve perfusion, giving crystalloids when necessary to supplement them with electrolytes. And occasionally we'll think about giving fresh frozen plasma. As well as having all the coagulation factors and all those sorts of things, it has something called alpha-2 macroglobulin, which is a protease inhibitor. So with these enzymes that are being released from the pancreas and starting to digest things in the body, so the fat and the structures around the pancreas, the protease inhibitors will stop that from happening. And fresh frozen plasma is one way that's been suggested to try and limit that. It's quite an expensive and not particularly effective way of trying to do that. So we don't potentially give that quite as often as we would do historically. And trying to limit things like vomiting, using antiemetics, trying to make sure we're getting nutrition on board earlier rather than later has definitely helped to improve survival. Sometimes we'll think about bypassing the pancreas by using jejunostomy tubes and those sorts of things. And if animals really can't keep food down, then we would use parenteral nutrition and intravenous nutrition if we needed to. In dogs, using antibiotics is a bit controversial. We don't know what the causes of pancreatitis are. Most of the time it's described as being idiopathic. In people, pancreatitis is either caused by infection or by alcohol abuse. They're the two most common reasons, and lots of other causes. In dogs, we don't tend to document ascending infection in the same way as we do in people or in cats. Ascending bacterial cholangiohepatitis and associated pancreatitis from reflux of gut material up into the pancreas is quite common. But in dogs, we don't really tend to see that animals have infectious pancreatitis. So we don't normally cover these animals with antibiotics unless there's another reason that they're very systemically unwell, there's a risk of gut translocation, or we're doing lots of interventions that mean that there's a risk of ascending infection. And gastroprotection can be quite helpful, so antacids, things that try and limit acidity in the gut to try and make these animals as comfortable as possible. So that's how we manage Meg. Meg actually did quite well. She recovered quite nicely from the pancreatitis and went on to make quite a good recovery. Yep.
You never ever use steroids?
In treatment of pancreatitis?
Yeah.
No, I don't think there's a rationale to use steroids. Sometimes we'll use them as the part of treatment for triaditis in cats, where we're treating inflammatory disease within the intestine as the causal reason for that. But in dogs, we wouldn't use steroids. We'd use them for treating other things if we needed to, and I don't think steroids necessarily worsen pancreatitis, but we wouldn't use them in terms of treatment, no. Cool. So another interactive case. This is an 8-year-old female neutered German Shepherd dog, and I'm afraid I can't remember what this dog's called, so it's an older German Shepherd. The presented collapsed, pale mucous membranes, capillary refill time is a little bit prolonged, but tachycardic and got poor peripheral pulse quality, so this dog is in hypovolemic shock. On abdominal palpation, we can suspect that there's a fluid thrill, so as we're ballotting the abdomen, it's moving backwards and forwards. And being an older German Shepherd that's collapsed, got very pale mucous membranes, splenic mass or bleeding splenic mass is going to be fairly top of our list of what's causing a problem. So how we're approaching this patient and generally trying to improve things is fairly similar to the other patients. We're going to place an intravenous catheter, going to consider whether we need to place two catheters because we want to try and get fluids into this patient very quickly. Which fluid are we going to give? Well, in the first instance, that's going to be crystalloids, and we're going to give it quite quickly with our bolus approach. And then analgesia and diagnostic tests are going to throw from that. So you're going to want to make sure this patient is comfortable. What analgesia would you consider giving this dog in the first instance? So we've got 5 choices for this. We've got morphine, we've got buprenorphine, butorphanol, pethidine or methadone. So make your choice. So just a couple of people left to vote. Cool. Okay, so most people going for methadone. I guess some of this may sort of be on the course of local availability as well in terms of which drugs are available. Interesting that a lot of people are going for butorphanol because butorphanol isn't a very good analgesic drug. It's not particularly long lasting and doesn't really have as good opioid analgesic properties as maybe morphine, pethidine or methadone do. So I would definitely use a full opioid agonist if at all possible, and methadone or pethidine would be my treatment, my analgesics of choice in this instance. Pethidine's a very potent opioid, but it also has quite good sedative effects. So if we were doing x-rays or wanted to do evaluation, that would be quite helpful for us. Methadone would be quite useful because it provides good analgesia that we can top up if we need to, fairly similar to morphine. Although morphine potentially will cause vomiting, we can use it, that's not a problem. Buprenorphine is a very good analgesic. In cats, it's been shown to be fairly equivalent to using morphine in thermal studies, or noxious thermal studies. It's very equivalent in terms of the degree of analgesia it produces. But in dogs, it has this sort of, and cats, it sort of has this ceiling effect. It's got this bell-shaped curve that the more buprenorphine you give, you start to antagonize it and you get reduced analgesia as a result of that. So probably wouldn't use buprenorphine here because there's a likelihood this dog's going to go to surgery, and it may be that we need to add more analgesia. So using a full agonist like methadone would be a good choice. So I'd probably stick to using methadone where possible. If we didn't have methadone, I'd use morphine or pethidine, and if we didn't have those, then buprenorphine, and would use butorphanol last. So here we did abdominocentesis. We just did this blindly, very quickly. We're just caudal to the umbilicus here. So this dog's got a little outy belly button here, and we're just behind that, just with a spinal needle, just collecting some free abdominal fluid. And this is bloody. So this dog has a hemoabdomen and is bleeding as a result of that. So we know this dog is bleeding into its abdomen. We need to check some blood work to make sure that there isn't a coagulopathy, and we probably would do some imaging to make sure that there was a splenic mass, but this needs explorative surgery to try and work out what's going on. If the dog is bleeding into its abdomen, then trying to increase abdominal pressure can be helpful. It is quite hard though to do this, and you actually need to wrap the belly quite tightly to increase abdominal pressure above arterial pressure. So trying to stop arterial bleeding by placing a belly wrap is actually quite hard to do, and this is some colleagues trying to do this. If you've got a dog post-bitch bay, for example, that's bleeding a little bit, then maybe you'll be able to do that. But in a dog with a bleeding splenic mass, it's actually going to be quite tricky to do. But placing the dog between two tables and really tightly wrapping around its abdomen would be effective in terms of doing that. And if you are able to manage to stop the bleeding, releasing pressure slowly just by gradually cutting the belly bandage so that you're not releasing that pressure all in one go would be very helpful. So we generally try to do that very gradually over a period of time rather than releasing the belly wrap all in one go. So this dog had quite aggressive fluid resuscitation. We gave 2 20 ml per kilo boluses of lactated ringer solution. That didn't help to improve peripheral pulses. So once our crystalloids have been exhausted and we're not seeing that there's improvement, we move on to giving gelafusine, which is a small molecular colloid to help improve perfusion. That did help to some degree. The heart rate came down a little bit, but there's still poor peripheral pulse quality. We've got an anemic dog, so PCV is 22%, and our total solids, which is a refractometer assessment of the amount of protein that's present, reference range is about 60 to 80, so fairly equivalent to total proteins, is low. So this dog has lost whole blood, and deciding what we do next after that fluid resuscitation would be to think about giving this dog a blood transfusion or to give it oxygen carrying support with oxyglobin. So this dog did have a really nasty splenic mass. This is its spleen after surgery. Surgery went well. The mass seemed to be encapsulated within the spleen, although it looks pretty horrible. It weighed several kilos. The dog's going to feel better as a result of having it removed. There was no gross evidence of any metastasis within the liver that we could see, or the rest of the abdomen, and the chest looked fairly unremarkable on our x-rays. So unfortunately, it's very likely that a splenic mass is hemangiosarcoma. We use the rule of 2/3, that 2/3 of splenic masses will be malignant and 2/3 of the malignant ones will be hemangiosarcoma. So about half of splenic masses will be hemangiosarcoma. The fact it's ruptured, does that make that more likely? But we do sometimes see benign splenic masses that rupture. So the fact that it has ruptured doesn't mean it's definitely going to be a nasty tumour, but the owners need to be aware before they go to surgery that we have hemangiosarcoma on our list of differentials, because hemangiosarcoma isn't a good disease. Just wondering, just as a straw poll, what do people feel that the median survival time for hemangiosarcoma after surgery is? So this dog's had a ruptured spleen, it's got a hemoabdomen as a result of that. If we don't treat it with anything else, so no chemotherapy, what's the average survival time after surgery for hemangiosarcoma? Three months. Yeah, so everyone agrees that 3 months is where we are. So surprising, but 3 months is what's reported in several papers in the literature. It's quite difficult because these dogs often feel better after surgery. We remove a mass that's been there for some time. They often feel much better, but we'll see metastatic disease in most patients, and about 98% will develop metastasis at some point, and they succumb quickly as a result of that. So owners need to be aware of that if we've got hemangiosarcoma on a list of differentials, that it may not be the right thing to take this patient to surgery because the survival time if we do nothing after surgery is quite short. We can extend that survival time if we use chemotherapy, if we use doxorubicin. There's lots of protocols that have been reported, but the average extension is by about a further 3 months. So average survival time of around 6 months if we treat with chemotherapy. So really not good news to find hemangiosarcoma because the survival times are quite short after surgery. So the surgery goes well. We've removed the spleen. Our pathology proves that it is hemangiosarcoma and that there are no evidence of metastasis. But the dog on recovery starts doing some weird things, and we get quite an irate call from our ward nurses because the ECG starts to look like this, and they're getting slightly worried about what's going on. So next question is, what's this rhythm? What's causing this ECG change? Is this a supraventricular tachycardia? Is this a ventricular tachycardia? Is this atrioventricular dissociation, or is this a left bundle branch block? Sorry, I don't think everyone finished. Sorry, I can't go back. Anyhow, most people think this is ventricular tachycardia, which is correct. It is a ventricular rhythm. It's not forming the normal QRS process. These are normal complexes, so there's probably a slight delay before the P wave, but there's normal QRS complex. They're just slightly smaller because the ventricular rhythm is so large. This is ventricular tachycardia. It's occurring more rapidly than we'd like just by ventricular premature complexes, and there are runs of them. And this isn't particularly uncommon after splenic surgery. Abdominal change will cause ventricular rhythms, the reason for which we're not fully understanding at the moment. There's thought to be myocardial depressant factors which are released from the spleen in the same way as they are with GDVs, for example, that change the rhythm after surgery. But ventricular tachycardia isn't uncommon for us to see after surgery. So I guess the next question is, when would you treat ventricular tachycardia? And you can choose more than one option here if you want to. So the options that we've got are is that it always needs treatment, that we'd only treat it if we saw multifocal complexes. We'd treat it if we had hemodynamic compromise. We would always treat it if the heart rate got over 160. We would treat it if we had the R on T phenomenon, and we treat it if it was Torsades de Pointes, which is a specific form of ventricular tachycardia. So you can press as many buttons as you like. Okay, so I'll let people have a bit more time because we've got about halfway through, so a few people must be still voting. I don't know why my computer's dropped off the bottom part of the number over lunch at some point. Grand. So we've got a number of different answers. We've got some people that say it always needs treating. That it would treat it if there was multifocal complexes, that there would be if there was hemodynamic compromise, and a lot of people, 40%, saying that they would treat if the heart rate was over 160. And it really depends what the ventricular tachycardia looks like. Generally, we tend to treat it when the complexes are multifocal, so we're seeing different areas of the heart being affected. When there's hemodynamic compromise, i.e. the rhythm is affecting the perfusion of the animal, and also where there's the R on T phenomenon. And I apologise because we haven't shown a picture of the R on T phenomenon, but that means that the complexes are getting very close together, and it's a precursor to ventricular fibrillation, and that's something we want to try and avoid as much as possible. So we would go for B, C and E. So we don't always have to treat ventricular tachycardia. It's not something that we always have to intervene and try and treat. Here, this is pretty nice VTAC, if there is such a thing. It's quite nice and regular, it's quite even, and it's quite a slow rate. And in this dog, this wasn't causing hemodynamic compromise. We know why it's there. It's secondary to the surgery that the dog has had. And if it's not causing a problem, then we wouldn't elect to treat it. The difficulty with antiarrhythmic therapy is that we can make things worse. All antiarrhythmics have a pro-arrhythmic property as well. And so we can actually make arrhythmias worse by trying to intervene to make them better. This is a VTAC that we probably would start to think about intervening with. Here we've got VPCs that are just occurring intermittently, but they're slightly multifocal. This one looks different from this one, for example. And then here they're starting to run into it a little, each other a little bit. They're not fully recovering before that's happening. And then here that's sort of occurring a bit more obviously that they're starting to run into each other. So I probably would start to treat this ventricular tachycardia. And here we've got sort of more saw blading of the ECG, and this is what I mean by R on T phenomenon. One complex hasn't finished before the next one has started, so it's starting to look like a fairly wiggly line. It's going up and down and saw blading. This is going to, if left untreated, potentially change into ventricular fibrillation, and that may cause a problem. So we definitely want to treat it if we saw the R on T. So the next question, I guess, obviously, is how would we treat the ventricular tachycardia? And we've got lots of different antiarrhythmic drugs that we can try to use to treat. We've got esmolol, so beta blocker, soltolol, another beta blocker, lidocaine, procainamide, or we could try and do some vagal manoeuvres. So what drug would you reach for in the first instance to try and treat ventricular tachycardia? Okay, so you've got one or two more people to vote. Okay. Hey. So most people are going for lignocaine, and that would be the drug that I'd reach for in the first instance. It's very effective in terms of treating ventricular tachycardia. Tend to use it as a bolus. If it doesn't work, then we would potentially repeat that bolus, and if it does work but keeps recurring, then we would think about a constant rate infusion of lignocaine to try and control things. If the lignocaine wasn't able to control things and we gave several boluses, or that we saw seizures as a result of that, and we can fairly commonly see those in cats, for example, then esmolol would probably be the second choice. It's a beta blocker but has a very short half-life, so if we make things worse by giving it as an antiarrhythmic, then we don't have to wait very long for those signs to start to wear off and for us to see recovery of the rhythm. So I think that's a good place for us to stop. If anyone's got any questions, we'll have a short sort of 10-minute break or so, and then we'll talk about trauma after the break. Thank you.